You're listening to the Innovation in Healthcare podcast, produced by Health Innovation North East and North Cumbria, proudly improving health and care for everyone. This is the second episode discussing the impact of cardiovascular disease on women's health and the programmes we are supporting to improve prevention for those at risk. If you haven't yet listened to the first episode, you can find this on our website at healthinnovation.org.uk/podcasts.
Hello, I'm Casey Taylor. I'm the Women's Health Programme Lead for Health Innovation North East and North Cumbria, and I'm here with some of my esteemed colleagues to talk about women's health, about its impact on cardiovascular disease and the role that inequalities in our communities play to the better screening, prevention and treatment of cardiovascular for the betterment of our region. So to introduce my colleagues, I have here Julia.
Hi, I'm Julia Newton. I'm Medical Director at Health Innovation North East North Cumbria.
And we've got Saira.
Hi, I'm Saira Malik. I am a GP in Sunderland and I'm also the North East North Cumbria Integrated Care Board Cardiovascular Disease Clinical Lead.
And Tracy.
Hi, I'm Tracy Marshall. I'm a CVD Programme Manager for Health Innovation North East North Cumbria, and I'm also a pharmacy technician by background.
So, thinking about menopause in some of the groups and populations that we see and cardiovascular disease, a lot of the patients or the communities, language might be an issue. It may be that English isn't their first language. How do we encourage those communities to get more support, particularly around the menopause, getting advice, reducing their risk?
Great question, Julia. So when we look at the statistics that we hold, we know that our populations from the more deprived backgrounds experience higher numbers of heart attacks and strokes and poor health outcomes. But we also know within that our Black and ethnic minority ladies have a higher rate of all-cause mortality from heart attacks, which is quite concerning. So I think you're right, language is of huge concern because as colleagues have discussed around the table, there is not a word for menopause in many cultures or different countries. They have no concept of menopause being a condition, which can often lead to women experiencing that disparity in the care that they need. But I think we're really lucky because we have such a collaborative effort going on in health and social care within the North East and Yorkshire areas that we can work with our voluntary sectors and those individualised groups, charity groups that are looking to improve women's health overall. And I think women can certainly always access help and support from their GPs, but if they are experiencing problems getting access, our pharmacists are very clued up on how to diagnose and direct treatment for menopause and signpost to the GPs as well. But we can also use the voluntary sector charities as well to start having that dialogue and raising the awareness of what menopause is to individual women.
Yeah, and I think that's great. We have got some really good examples of working with particularly the voluntary sector in North East North Cumbria. Tracy, you've been working with some groups down in Middlesbrough area and Gateshead. Mm-hmm. What's been your experience with the women that you've been doing healthy hearts checks with?
Yeah, so as part of one of the programmes that Health Innovation did last year, we ran some women's only sessions for healthy hearts. We took height and weight, did the blood pressure, and we also used a point of care finger prick cholesterol test. And I think one of the things to note as well with cardiovascular disease, that a lot of the kind of conditions that come under cardiovascular disease are asymptomatic. You don't have any symptoms, so until you check your blood pressure or you check your cholesterol, you don't know that they're not within the healthy range. And the experience that I had last year in these kind of in the women's hubs, it was absolutely amazing. The women that came along were fantastic, and the sense of community that they had. And I was saying to Saira earlier, you would test one lady, and then the next week she'd bring a sister or an aunt or a mum down to say, I want my mum testing. And we did have some language barriers for some people, but we did set up a bespoke session for Arabic ladies with the translator, but some of the volunteers that we had there, they helped with some of the language issues as well. And the overarching sense that we had following the health checks was that these women were so pleased that we'd been able to kind of take something into their community and somewhere that they could go where they felt safe, that they trusted, that we were kind of giving them that information in kind of somewhere comfortable for them. I always say this, and it probably sounds a little bit cheesy, but it was actually one of my highlight careers doing this work, because I absolutely loved it. Just felt as though you were kind of making an impact into those communities.
And what kind of things did they describe as the barriers to why those communities weren't accessing the current structures that we have to try and look at risk for cardiovascular disease in women?
Well, we did. We actually spoke to one of the volunteers one afternoon, and she was really helpful. She didn't mind us kind of asking any questions. Some of the barriers are the language barrier. Some of it is because they're a woman as well, and they want to see a woman healthcare professional, and that might delay kind of seeing somebody, or that they might not be able to see somebody at all. Some women would potentially want to take their husband with them as well. And so then it's kind of putting that barrier in place, would have to wait for the husband to be able to go with them, and just actually being able to feel comfortable and talk to somebody. I know we were there to do healthy heart checks, but because we were giving them our time, and it was dedicated time for each woman, they ended up talking about other things such as the menopause, and just asking questions around, other little things that they might think are trivial, but actually it could be quite important in kind of that healthcare setting, and just empowering them, I guess, to kind of come up and ask those questions.
At the end of the day, one of the things that I worry about is the use of the language that we use. And one of the things you've told me, Tracy, is that we use cardiovascular disease, and we know what that is, but when you talk to particularly the women, but other communities, who don't have the same level of knowledge around health, the words cardiovascular disease are meaningless. Yeah. So hence why we use the word healthy heart checks now, which,
yes.
Do you think that makes it easier for women to understand, or not just the women, but the communities to understand?
I think it's easier for everybody, really. I've been working on outreach buses recently, and we've been inviting everybody that wants a healthy heart check to come on the bus. And as soon as you kind of say, it's a healthy heart check, it's automatically kind of understandable for them, and then we explain what it is, about the blood pressure, and we use that as a kind of some education. So when we have them in that dedicated space again, we can give them their education around anything to do with potential problems that can lead towards an unhealthy heart. So,
do you think they understand why the tests are important? Because another thing, we send invites to people to come in for NHS health checks. Primary care sends out appointments for people to come in for regular chronic disease testing. But sometimes I wonder whether people actually understand why we do that. Is it the prevention agenda, I suppose?
Yeah, I think some people do and some people don't. I don't think some people realise, what it is to have high blood pressure and what that can lead to. Or I remember having a discussion with somebody once who said, I didn't know that having high cholesterol could lead to a heart attack or a stroke. Yeah. I just thought it made you fat or overweight. So I think there is that those barriers, and we have some booklets that we kind of give out, and we explain all of the risks and why we're doing what we're doing, and we want to try and make that as easy and accessible to read as possible. So we are kind of looking at going down that health literacy route. And we are kind of hoping to put that into different languages. But I know I've spoken to Sarah before, and it's not as simple as translating it into a different language. So there are kind of some of those things. And I know I had to try and use a Google Translate in some of the sessions that we had last year. And it's not that easy. And like Sarah said, in some cultures, there isn't a word for menopause as well. So you do have to kind of try and put it into a perspective that they can understand. If you're open to those conversations, then they will ask you the questions as well.
Mm-hmm. And the sessions that you ran, do you think the groups benefited from the engagement? Do you think, what was the feedback that you got?
Oh, we got some amazing feedback. Some women that had already had heart attacks, and even they said, they hadn't realised what their ongoing risks could be, but they were prepared to kind of take more notice of the health and the results. And I think educating people about their numbers, so, what does a cholesterol level of 6 mean? What does that mean to anybody? And just kind of trying to break that down into, we have the good fats and the bad fats, and making sure that they kind of understand that and they know their numbers. We do this with high blood pressure as well. And I think that just being able to kind of explain that to people in a way that they understand it empowers them to then kind of take control of their health.
Yeah, that sounds like there's lots of really exciting innovation going on, and and it makes me think about the shift towards prevention, and away from analog to digital. What kind of other exciting things might there be to help us with prevention?
There's lots of things. So there's lots of apps. There's kind of, the point of care testing that we do. You can actually do cholesterol testing in your own home now if you wanted to. And like I said, the BP kiosks that are becoming more and more accessible for people. We do have to be mindful of digital exclusion as well, because we do have those communities and areas within North East North Cumbria that are kind of high on the deprivation and disadvantaged deciles as well. So we can't completely go digital. But, there's even things like your smartwatch. I actually found out I had hypertension because I was calibrating my smartwatch.
Wow.
And I had to do my blood pressure and calibrate my smartwatch, and I was looking at it going, that can't be right, surely that's not right. And I did it a few times, and I ended up going to the GP. And again, I work in this space, well, actually I think slightly just as I started working in the cardiovascular disease team, and even I was kind of taken by surprise that my blood pressure was so high, but it's because there is no symptoms. So even something as simple as kind of calibrating a smartwatch or a Fitbit or whatever kind of got can kind of lead to those people going to the GP and then getting diagnosed. So, and then because of that, you end up getting the information to make some of those lifestyle changes as well.
How do you think, Sarah, that we could better support women to access healthcare to improve their heart risks?
I think we need to empower women. I think we need to enable them. We need to give them the information that they need to make decisions about their own health. I can't stress how important it is for us to be aware of our life journey and how at different points of our life our health will change, and what we can do to remain as healthy as possible. Prevention is always better than cure. I think that's been drummed into all of us from a very long time, and we know from our ICB Women's Health Strategy, for every £1 that we spend on women's health in our area, we save £5 in the long run. So there is significant socioeconomic reasons for supporting women into staying as well as possible. And I can't stress enough as well the importance of going for your health checks as well. I know at the minute we only do health checks over 40, but there's no reason why you can't approach your community teams to have your numbers checked, have blood pressure or otherwise at a younger age as well. But we know that we have a very low uptake of health checks across our region, and I often feel that the health checks are a golden opportunity at quite a crucial juncture of change in women's lives. It's when we're just kind of going into the perimenopause phase, or in some ethnicities, for example, some South Asian ladies can actually start going through perimenopause, menopause in their 30s as well. So the quicker we identify those ladies at risk, and the quicker we optimise their treatment, whether that's with HRT or with statins or with empowering them with the right advice and lifestyle choices to improve their health, the less the outcomes will be of cardiovascular disease and its sequelae in these individuals.
Similar question to you, Tracy. How do you think we can put in place systems to support underserved communities to access healthcare to reduce their cardiovascular risk?
So we're actually running a programme called Healthy Hearts programme with Health Innovation in collaboration with the Integrated Care Board as well. Because as we know, people from different ethnic backgrounds and people in certain areas of deprivation, their cardiovascular risks are increased for different reasons. Some of it's because of their ethnicity, some of it's because of that smoking, alcohol, sometimes in the severe mental illness space as well. They're more likely to kind of have those cardiovascular risks increased because there's more prevalence of kind of smoking and things like that as well. So we are trying to take those health checks into those underserved communities. So we don't have an age limit on the people that we check. So if you're over 18, you can come and get a healthy heart check done, because as we've said, it's quite important in some people to get those risk factors identified earlier in somebody's life. I think taking those tests into the communities and making them more accessible has been very successful. Well, we found a lot of success in that area. And so over the next 18 months, we will be working across our region as well to take our healthy heart checks into those different areas as well. And I just think that if you make something a little bit more accessible, people are going to be more likely to kind of attend. I know that we've got colleagues up in Northumberland who are also doing sessions on an evening as well. And I know when we did the women's hubs last year, we did evening sessions for people who were at work or kind of couldn't get there during the day. So it's just about thinking about how we can make it more accessible for people. Because I think on the whole, people are invested in their own health. We just need to make it a little bit more accessible for them.
I was wondering a little bit about the diagnosis and how long does that take between, people are being screened in communities now, which is heartening. And then there's all those, your toolkit of drugs you've talked about for your treatment. What's that process in the middle for the diagnosis? What's the typical pathway and length of that? And could innovation, different tools that it would be at a clinician's disposal, speed that up and maybe improve the patient journey?
I think when a patient comes in, I think we just have to be very careful, because when patients come in, we know that up to 40% of them are hyperventilating at the time of contact with a healthcare professional. So what you don't want to do is overdiagnose and give people medications when they don't need them. So if I find that a patient comes in, they don't have any red flag symptoms, which is headaches, visual disturbances, vomiting, sickness or abdominal pain, I will give patients a sheet to monitor their blood pressure twice a day and hand it back in 7 days' time. If they are acutely unwell, I will be liaising with my hospital colleagues to see whether they need admitting or not and starting them on treatment. And if patients are kind of interim those two phases and they do have some symptomology like headaches or visual disturbances, there is a pathway that we have in general practice primary care, and we would start patients on medications.
And then my other question was a bit of a big topic, but we've talked quite a lot there about women's health and about access to treatments and care and things. I actually wonder about the role of a community or men in women's health. I'm mindful about a year ago I went to a women's health conference, and I would honestly say about 5% of the attendees out of maybe 150 people were men. And I'm wondering how important it is to have the men supporting the women's health agenda, or do we just have a health agenda?
That's a good question. And I think the holistic part of me would say that we do need a health agenda, because obviously men have issues, women have issues, and we need to recognise the variances that our different hormones cause us to experience different health problems in different ways. I think the reason I'm focused in on the women's health agenda and quite an advocate of it is that we know that the area is under-researched. It's undertreated. We're still playing catch up with women's health in the world, not just the UK. So that concerns me. And that's why I think we do need a focus on women's health until we have that levelling up and a lack of disparities between men and women's health. I think once we get to that stage, then I think we'd be quite comfortable to say, actually, now we're on a level playing field and now we need to equalise everything. But until we get to that point, I'd like to see a focus on women's health continuing as it has been.
For my husband to be more educated about some of the things that I'm going through in menopause, I think that helps a relationship as well. Just for your partner or family members to be able to understand what you're going through is really it's reassuring. So there's quite often I've sent my husband, links to articles and things to read, and I just think that it is needed, definitely. I went to a webinar last year for International Women's Day, actually, and there were 2 fantastic men speakers on there as well who were massive advocates for women's health as well. And so I do think it's becoming more and more popular for men to be involved in that space, and I think it's needed. I think just having that equality over the space is definitely needed. Yeah.
My male colleagues are extremely supportive and very invested in making sure that any projects that we're involved in, focuses specifically on underrepresented groups or on female groups as well. So I think it's just having that collective, collaborative approach and the recognition that, our male colleagues are interested and they do want to help. And you're right, Tracy. I think I often find that, seeing patients as I do, ladies are more likely to come in and say what's happening with my partner and ask questions on behalf of their partners. Mm-hmm. But whether I see it the other way around, I can't say that I haven't had male partners come in and say, my wife's going through menopause, what can I do? So I think if we could somehow shift some of that narrative and empower our kind of male colleagues and family members, I think that would really go a long way in changing not only the discussions that we have about health, but also the outcomes that we have for health as well.
Well, thank you very much, ladies. It's been a really inspirational talk, and I've learnt a lot from listening to you all. So really thanks again for all of your input into this really fascinating subject, and hopefully, like you say, we'll be making strides ahead as a community to make sure that people get access to better care and take advantage of that.
You have been listening to the Innovation in Healthcare podcast, produced by Health Innovation North East and North Cumbria. If you'd like to find out more about our women's health strategy, please visit the Improving Population Health page on our website at healthinnovationnenc.org.uk. We will, of course, provide further links and resources in the podcast show notes. Thank you for listening.